Good morning, everyone. This is the third lecture about stroke rehabilitation, probably the last one as well. And then we are going to move on some other topic. And as in the previous lectures, I already talked about different type of strokes, ADLs, IADLs, and just the basics of stroke treatment. And in the previous lecture, we were discussing about different rehabilitation options available for aphasia, shoulder pain, and things like this. Plus, I talk about what are the initial things or initial difficulties which are encountered in patients who have stroke. And and one more important thing, of course, whatever we are studying in stroke, and of course, like those things can be implied in other um, settings as well. Of course, like any condition which give paralysis or paralysis or dysphagia, XYZ, of course, like the same strategies will play a role in those cases as well, not just in the case of stroke. Last in the last lecture, we left our discussion at subacromial impingement, and today we are going to talk about post-stroke depression. So, post-stroke depression, again, it's again a very common thing. Now, the important thing, as you can see over here, that it could be present in early or late phase, and there is negative impact on function. Um, uh, there could be two reasons why there is stroke depression or post-stroke depression. The one is basically the organic one, which can be due to as the brain get damaged. Uh, so maybe there is some catecholamine depletion in that area, especially the frontal one. Or, for example, if there is any damage in the dopaminergic or serotogenic or like any of the you can say hormones, as the brain is still the functions of the brain are still a big research area, and uh, like many of the hormones are already known, or you can say most of the neurotransmitters are already known, and many are still discovered, and what are the changes which occur after post stroke, these all things, of course, um, are there. So and the other reason is, of course, like anyone who have stroke, it's a big change or a big loss in the life, um, a physical loss. So of course, many of the patients, they become disabled, so it's quite understandable that they will go in stroke. um, so again, of course, like it's a depression, so a psychiatrist can deal it better, but what they do is like when anyone have what you can say is true depression, so they treat that in the traditional way. And whenever anyone have depression, of course, first of all, we refer them to psychologist, and the psychologists basically um, give psychosocial support, or they do something called as talk therapy, try to make the things better. Many patients, they can get benefit out of it, and of course the other treatment is putting the patients on uh, pharmacotherapy, or you can say drugs, in which like we have number of options like SSRIs, selective serotonin reuptake inhibitors, or TCAs, which are tricyclic antidepressants. But as we know, like SSRIs are newer than TCA. TCAs have more side effects. SSRIs are comparatively um, safe, and also SSRIs have a better effect than TCAs. So here it is written cognitive behavioral therapy. It is basically a form of, you can say, psychotherapy, right? Cognitive behavioral therapy. So CBT is done not just in depression, rather in anxiety disorders and different disorders, like they do go for CBT. So simply, you can say that post-stroke depression uh, is they deal it in the same way as they deal depression in normal person. Okay, so same, um, you can say same treatment strategies will be applied to the patient, and same modalities will be used, like pharmacotherapy, psychotherapy, and all the stuff. So this is how they deal with the post-stroke depression. Um, Driving. So see, like driving, basically it promotes independence, or you can say sense of independence, and help avoid sense of isolation. So neurophysiological testing for person with cognitive or behavioral disorders. Simulated driving tests can be done, and um, there is driving assessment and rehabilitation programs available. Like, of course, not in every country, but in the countries where the health system is very advanced, or you can say first world countries, of course, they have these kind of things. So, uh, and again, like as we know that driving is one of the IADLs as well. Then what they do is like, um, of course, one of the thing or one of the aim is to put the patient back in the society or in the community, and because like not all the countries they are same. In like most of the countries, when you work, you get money, and when you don't work, of course, like you are dependent on, or you, like will be will be dependent on something or someone. So of course, like like occupational therapists, and there are vocational therapists, like therapists like this, who basically help in this regard. So of course, it's an important determinant of the quality of life, and work hardening therapy can be given in greatest opportunity to support vocational reintegration are in the areas of education advocacy. So again, like there are different institutes, so they can put the patient back. So you can see over here, rehabilitation toolbox, pharmacological agents are there. I will talk about this one in a while. Constraint induced movement therapy, mental imagery, functional electrical stimulation, transcranial magnetic stimulation, transcranial direct cortical stimulation, virtual reality, and robot technology. Now, um, basically, there is like a lot of traditional methods and a lot of new methods which are applied in stroke rehabilitation. And nowadays, of course, things are better than before. Um, there are different ways by which they treat the patient. For example, you will see here, you can see over here, like for pharmacology, we can put the patient on SSRI, dopaminergic agents, acetylcholinesterase inhibitors, donepezil. Like this one is the one which is given in the patients who have dementia as well. So all these drugs like can be used, like depending on the condition of the patient, not in all the patients. So depending on the condition of the patient, these drugs can be used. Okay, CIMT. So what is CIMT? CIMT is basically uh, constraint induced movement therapy. So we all know, like either we are right-handed or either we are left-handed. So if you will see the photograph over here, okay, maybe this person have a stroke in of the right hand, and what they have done, they have sorry, maybe this person have a stroke of the left hand. So what they have done, they have put a constraint uh, on the limb or on the arm which is not affected. So it's quite normal that if someone have paralysis of the right hand, of course they will start doing everything with the left hand, and they will you can say uh, they will not even try to use their right hand. And as again, I will take you back from my first lecture on rehabilitation, in which I told you about plasticity. The brain have plasticity, and new neuronal connections can be formed, but if like we will try to form them. So see, in this one, they have constrained the good limb or good arm so that the person will use the affected arm. Okay. So see, like he's putting, of course, a T by his left arm. Uh, so of course, like one of the thing which is you don't have to remember like how much degree of movements are there, but what is this like? There should be some wrist and finger function before starting this one. Like, of course, if anyone cannot move the paralyzed arm, and you will put them on CIMT or constraint induced movement therapy. So, of course, like even if they will try, it is not going to work for that patient. So, of course, like as we know that brain have neuroplasticity, and by doing this thing, like it brings back or it recovers the motor functionality. And now you can see over here excite trial. So of course, like this is a study which was conducted, and many other studies were conducted as well, which shows the effectiveness of constraint induced movement therapy. So, of course, like constraint induced movement therapy is indicated for all those patients who don't have a spasticity, or you can say like don't have much spasticity, and there should be some of the functionality is there. Okay, so remember, like we should not start this constraint induced movement therapy uh, right after stroke, because remember, like right after stroke, the muscles goes into flaccidity, and later on there is spasticity. So wait for uh, some of the spasticity to reduce, plus uh, some of the limb movements to come back, and then we can put the patient on, you can say, constraint induced movement therapy. So of course, like then it will be helpful. And if of course, like if there is spasticity or there is no movement is there, so this therapy is not effective in those cases. So this is about constraint induced movement therapy. Other than that, uh, uh, okay, this is mirror therapy. So what is mirror therapy, by the way? Mirror therapy is basically helpful. If you know, I was talking about hemi neglect syndrome, okay, or hemi neglect, like the patients basically uh, they they ignore the right or the left side of the body, the persons who are affected by that. So what happens is, this is very important, that mm, what they do, like um, they can uh, they can get help from this. And the other use of this thing is, um, like for example, if there this limb is affected. Okay, I will show you one more photograph. See, for example, um, if uh, they have like paralysis of that, so they put a mirror in which they see this arm in the mirror, and they perceive it as their like other hand, right hand, right? So you can see over here form of motor imagery in which a mirror is used to convey visual stimuli to the brain through observation of one's unaffected body part as it carries out a set of movements. So of course, like when they move this one, there will be movement in the other, what you can say, arm as well. So this is one of the way. This is called as mirror therapy. This is also a way to do that. For example, like they are doing the same mirror therapy in a patient who have a leg paralysis. So mirror visual feedback is given through this. A strategy that has been used successfully to treat phantom pain after amputation may promote recovery from hemiplegia after stroke. The underlying principle is that movement of the affected limb can be stimulated via visual cues originating from the opposite side of the body. So, see, uh, this one, of course, they perceive it as this leg, and when they move this one, there is movement in the, like, of course, what you are seeing here is the same, the image of the same leg. So what you can see like use movements of a stronger upper limb or lower limb to trick our brain into thinking that the weaker arm is moving. So this is again mirror therapy, and you can see over here again they are showing you a mirror therapy in which like the person can see the same leg in the mirror. So of course like there is uh, see, in a pilot study, MRI demonstrated that brain areas that are involved in sensory-motor learning, mirror neurons are activated by the visual illusions from mirror therapy. So when the patient look the other limb, so they have found that there is formation of new connections or new neurons, right? New neuronal connections can be formed by this way. So this is one of the thing. Then comes the functional electrical stimulation, and we have talked about this thing before as well. And I told you that functional electrical stimulation can be used in many of the patients. The most promising technique for hemiparetic arm. So again, like this is some data. Okay, so you can see like times in stroke, 2 weeks, 3 weeks, 4 weeks, 5 weeks, and 6 weeks, and recovery of grip strength again. So now this functional electrical stimulation, they improve the ability to move the affected limb or use the affected limb in everyday life. Okay, so of course, like how they do it, they electrically stimulate. Like in the previous lecture, I show you that diagram, like the photograph in which they were stimulating. Okay, one of the thing is to develop motor like exercise therapy. There are different facilitation techniques like one of this thing is PNF. Okay, uh, like proprioceptive neuromuscular facilitation. So it relies on quick stretching and manual resistance of muscle activation of the limb in functional direction, which are often spiral and diagonal. So basically it improves their motor control. But remember, like all these therapies, they are needed for a long time. It's not like this that um, like you will try it today and tomorrow you will get the results. Of course, like physiotherapy on therapy should be continued for quite some time. So again, like this is the proprioceptive neuromuscular facilitation. Of course, this one is done by physiotherapist, or you can see like this is again exercise therapy to control, to develop motor control. So stretching and strengthening, attempting to retrain weak muscles through re-education. So they are doing that. And again, like this physiotherapy is needed for a long period of time, not like quickly we can get results. Okay. So like of course, and by the way, one of the thing like by this way is what we can help is the spasticity, right? Because as we know that spasticity also interfere with the function by limiting the active range of motion. So what they do, like when the physiotherapist, they keep on giving physiotherapy to the patient. Of course, like it helped to reduce spasticity, and of course, like it helps the patient in this regard. So this is basically exercise therapy, right? So what we have covered is constraint induced movement therapy. We cover about functional electrical stimulation, okay, and we discuss about exercise therapy. Okay, then there is gait training. Now I will not talk more about gait training because what I found in rehabilitation lectures is like there is a full video by your teacher uh, about gait training, how, and there was a video in English which is uploaded. If you couldn't found, it's under the lectures, like um, one of the video you can found in that one, because I was looking, I was going through the videos, and I found like there is a full video on gait training. Okay, so how it is done. So again, okay, this mirror box therapy, this is mental imagery. Yes, we have discussed this thing, and this is again functional electrical stimulation, which we have discussed. and again one more functional electrical stimulation. Okay, so this thing. Okay, now what is transcranial magnetic stimulation? Okay, by the way, these all are newer techniques, right? These all are newer ways or newer techniques. Okay, and maybe like depending on like where you are working. Okay, maybe or in which hospital you are seeing this thing, maybe you will not find everything over there, right? Because okay, and many of these things are basically under trials. Okay, like going under the studies, not just magnetic transcranial magnetic stimulation, but like many other techniques, right? So this one, again, if you will see over here, this is a non-invasive type of stimulation, and of course, like this one is a magnetic field. Okay, which um, you can say, you can see over here the magnetic field over here. Of course, like it gives some of the electromagnetic radiations to the brain. Okay, so now uh, what is the use of this thing, or how we know about this thing, is that these magnetic fields basically stimulate the nerve cells in the brain, and it helps to improve depression. Okay, and it is also used, it have what you can say, some of the side of good effects on the neurons, like to bring back the functionality, though it have few side effects like headache, like sometimes some tingling or spasm or twitching of face muscles or lightheadedness. It can lead to seizures as well, but like the side effects are not so, like these seizures type of side effects are not so common. Okay, so uh, now uh, you can say like this type of therapy have very rarely it can cause any serious side effects, otherwise the side effects are not so serious. Okay, so basically this one, okay, this transcranial electrical stimulation, um, like the main use is to treat depression. Okay, and the other thing, like it can help what you can say some of the neurons um, to uh, to remodel, you can say, right? So basically, uh, okay, this one is not just used in a stroke, but it can be used in patients of migraine as well. It can be used in patient of depression. Okay, and also nowadays, they are conducting research to use this one for other neurological conditions like epilepsy, like Alzheimer's, like Parkinsonism, and things like this. Okay, so of course, like this is a new technique, you can say, and many of the things are still underway, still under research. Um, then there is transcranial direct cortical stimulation. Okay, so or direct current stimulation, right? So if you can see over here, like in this woman, they have put the electrodes directly. Now, if you know that, in psychiatry, if someone have major depression or someone have suicidality, or someone is like their depression is not going away by only drugs, so what they do, they give them this electric shock therapy, right? So of course, like that brings back, or you can say it's a reset button to reset the neurotransmitters in the brain. So of course, like this one is basically a type of neuromodulation. Okay, and this one directly we put two electrodes, cathode and anode. Okay, and they pass current. So basically, the one of the use in this thing is of course depression. Remember, only major depression. Okay, and and that's why it is used. But again, like they are using the same technique in the patients to see like either it's effective in other conditions like anxiety, like neuropathic pain, And one of the thing um, that what they found until now, but again, like still we need some stronger data on that, is it do improve the activities of daily life, or ADLs, okay, after this transcranial cortical stimulation. So this is like about these techniques, okay. And basically in stroke research, like it's a new thing, that's why maybe you will not found in much books. In 2014 they found something uh, very promising, that when they do transcranial direct cortical stimulation, you can say it improved the you can say the motor activity, or in the upper limb of the patient, right? And also they found like the patients who have aphasia, they get improved after this transcranial direct stimulation. So again, like these are all the researches, of course, which they are still doing. They are establishing the data. Then virtual rehab, um, of course, like these are again some newer techniques which are used. You can see shown to have improvement in balance and gait. They can be immersive versus non-immersive, and for example, they're like, if you know that Nintendo games, or nowadays the games which are coming like Kinect, or um, all these games like in which you have to move and you have to follow something. So these devices can be used. Okay, one of a very important advancement, you can say, which is done in stroke rehabilitation, is the development of this robotic devices. Okay, um, if I'm not wrong, maybe um, recently, I think like 2019, they gave what you can say a very big, I think, Nobel Prize or something like this, to a person who basically um, help a patient who have a spinal cord injury and his lower limbs cannot move at all. And what they did, they make a big processes like this, like robotic device like this. They fix it to the person, and they connect that device to his brains, like when he uh, try to move his lower limbs, so it can get impulses from there, and it can start you can say functioning. So of course, like a very important thing, and this is the newest class of clinical tools, okay, but they are expensive, they are battery operated, okay. So but and they are of course available to very limited amount of people because of the price and all these things. So anyhow, of course, like we know that nowadays that there is a lot of newer development, especially in neuroscience, in computer technology, and these robotic treatments are basically uh, um, they are they are they're working a lot in this robotic technologies to um, improve the quality of life of the patients who have stroke. But of course, like there's still a long way to go. Okay. Uh, so again, like here you can see like the robotic technology, and yes, not just this thing, but one of the thing like how they can use the robots is to give the patients that um, passive movement. Okay. Remember, like active movement when you can move yourself, but passive movement when someone is helping you. So of course, you can say like this is the device, or this robotic device is helping her in walking. Okay. Basically, like what physiotherapists were doing, um, this one robot is doing that. So of course, like if a physiotherapist or anyone have to, or they try to make someone standing and let them move, so of course, like it cannot be done by one person, especially for those in which like both the lower limbs are paralyzed. So of course, like it needs two three persons at least to support the patient, to help them in walking. But of course, you can see over here, they have strapped her legs with this machine, they have given her full support, and that's how like this one is helping her to achieve uh, the, you can say, the passive range of motion, okay, of the paralyzed areas. So of course, like very 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 important type of development which is there, but again expensive. So again, one more thing, see, this is again the robotic technology. um, uh, if we will see how uh, they are playing the games by this one, and of course it is going to improve their, like make their hands move, and of course like improve their function. So these kind of therapies they are working on, and they are developing newer techniques. Okay, so okay, I think I did not talk about one thing, that is the bladder thing. So okay, well, I will add one more slide here, and the bladder problems. um, Basically we can say neurogenic bladder. Okay, as I told you, like the bladder abnormalities are very 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 common, right? So what happens, like whenever, like, neurogenic bladder is basically a general term which we use for bladder dysfunction from any neurological injury, right? And it is so common in stroke patients, like that around 60% of the patients who have stroke, they have bladder problems. uh, but the good thing about them is, in 90, you can say 60% have this or suffer from this. But the good thing is what, like 90% basically uh, gain gain back normal voiding in, you can say, around 6 months of time. Okay, in 6 months of time. So this is the good thing about this, like most of the patients, they recover. But whenever the bladder is involved, and again 6 months is a big time, you can say. uh, so we can help the patient by a number of techniques. For example, one of the techniques is called as timed voiding. Okay, like the void after, or urinate. Voiding means urinate, right? So time voiding, like urinate after some intervals, or like specific intervals. This thing is one of the thing. And of course, like um, what they do, by the way, they sometimes they pass a catheter, and they clamp it. So clamping means like um, they block the flow of urine so that the bladder can expand. And with time, basically they increase that time to train the bladder, to train the detrusor muscle, right? So this is the thing which is very 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 important or helpful in the patient. You can say like time voiding or clamping, as I told you, clamping with like gradually, you can say, increasing the time between taking off clamps or not. Okay, so these things. And again, like number of drugs are also available to treat this thing, or to help the patients from neurogenic bladder. So okay, what can be done other than that? We can regulate their fluid intake, but of course, like avoid any type of dehydration, because that you don't have, like, by dehydration there could be number of other issues which can start. And of course, like if there is no you can say betterment, then we can use medications. Okay, or we can go for urodynamic evaluation. Okay, like in surgery I talk about BPH, and that one I explain what is neurogenic evaluation can be done. If, sorry, evaluation, okay, can be done. Okay, so these things can be done. um, Now, Yes, so neurogenic bladder, then DVT, of course, like DVT is a problem in any bedridden patient, and whenever there is DVT, it will be treated the same way as what we have covered when we study DVT. Okay, I think internal medicine you have done that, so of course, like that thing should be done for the patients to help them or to avoid any deep vein thrombosis to occur, which can lead to pulmonary embolism or anything like this. So now you can see over here 1 in 10 functionally independent at time of stroke, and normally 1/2 are independent at 6 months. Now these are some um, the timelines to tell you like how the disease behave. Most improvements in activities of daily life occur during the first 6 months. Up to 5% of patients may show continued measurable improvement at 12 months of post-stroke. Okay, this kind of information is very, very, very important, right? Because you should not give any patient false hope. You must give the patient uh, uh, the right thing. Okay, so of course, it's it's a very common thing whenever someone becomes sick. So they always ask about when we are going to be fine. So remember, like the stroke patients, we can tell them that in the like we have to follow up. We have to see how you are doing, because generally speaking, people who do good, they show improvement by 1 month or 6 weeks, and most of the patients they get very much better by the end of 6 months, and very small amount of patients can get better by 1 year of 1 year of time. So things like this, of course, like these are very important things to answer the patient's questions. So predictor of functional outcome, I talked about this thing before. It depends on how severe was the stroke, what was the age of the patient, and what was the sitting balance. Okay, I talk about this thing. Like I told you that like someone who have poor sitting balance, who have poor trunk control, who have urinary incontinence, or who is like more than 75 years of age, uh, these all are very poor predictors for independent walking, especially, right? So because like of course we know that to walk we must have a very good lower limb power or coordination should be there. So of course like that's a very important thing. Okay, so uh, like that's how they predict the outcome. And one of the thing is admission FEM score, which we have discussed yesterday, right? What is FEM score and how what they see. So like of course like if the FEM score is lower, so which means like bad prognosis. But if the FEM score is better, so what it means like a good prognosis, right? So sitting balance is very, very important predictor, you can say, and that's why like they check either the patient have a good sitting balance or not, because if the sitting balance is good, it's a good predictor, a positive predictor, which will point towards that the patient will get better. Okay. Uh, Now, typical disabilities in some specific activities of at 6 months post stroke. 15% of the patients unable to walk, need assist transfer, 20% of the patient need assist while bathing, 50% of the patient, and need assist to dress, 30% of the patients. Okay, so this is the outcome, you can say, according to different studies. Okay, like after 6 months post stroke. So uh, you can see over here the poor prognostic indicators for upper limb recovery. Someone who have a very severe proximal spasticity, someone who have prolonged flaccid period, someone who have absence of voluntary hand movement at 4 to 6 weeks, someone who have onset of movement greater than 2 to 4 weeks, and full recovery is usually complete within 3 months of onset, right? Uh, so these are some poor predictors, um, like of upper limb recovery. Okay, all this one are the poor predictors. So the last thing, guys, in this lecture is like the prognosis. best neurological recovery is seen by 11 weeks of for 95% of the patient. Prognosis in patients with mild or moderate stroke is usually excellent. Most ADL recovery, okay, Barthel index, I told you, like, you don't have to remember this index, is by 12.5 weeks with daily physiotherapy and occupational therapy. But recovery could take 2 years or more, and periodic rehabilitation interventions may be necessary to maintain function. So, you know, of course, like, rehabilitation in stroke is very important, because once anyone have stroke, it's all depends like how much you like they try to stimulate themselves or they try to move themselves, because as you know, the all concept basically revolves around um, neuroplasticity. And if you we are not going to um, develop that neuroplasticity, of course, like, uh, the improvement will not be there, or the improvement will not be that much good. Okay, so that's why if someone, like, in the patients in which, like, they they do rehabilitation, and they they stimulate uh, the muscles, or they try to move the muscles, of course it brings more neuronal connections or new neuronal connection, and more recovery of the patient. So thank you so much, guys, for listening. And next lecture will be about some other condition. I'm planning to do one lecture on TBI, which is traumatic brain injury, and spinal cord injury, SCI, right? So why? Because these two are very much similar to uh, the brain injury. So of course, like, because we were doing stroke rehabilitation, and all the things which are done under this, of course, like, in those, the same things or the same type of issues are there. So we will do one lecture on that, and then we will move on other topics. So thank you so much, guys, for listening. I will see you around.